This episode is brought to you by Title IX and California Cryobank. We're super excited to have them on board, making our show a possibility.
Welcome to If These Ovaries Could Talk. I'm Jamie.
I'm Robin.
And we're your hosts.
We sure are.
Love is love if you don't have to make a family by taking a traditional route. If these ovaries could talk, they would say.
How do I get the sperm through custom?
I am a lesbian.
So gay.
So gay. We need to tell our stories.
It's not your nuclear family anymore. It's not just your mom and dad thing.
We're not ruining these little humans.
It's not for the gay reason. Just because we stink.
Hi, guys.
Jamie,
Yes.
tomorrow starts Pride.
Oh, my God.
Like the
you're
month
right.
of Pride. Sort of snuck up on us.
You know what's so fun about Pride? Like, before I had kids, Pride was always great, like, so fun. Like, yay, it's Pride.
It was like
Let's hang
boozy.
out.
Woo!
But now that I have kids in our house, it's become a really special holiday to my kids.
Has
like
it?
my
That's
daughter.
nice.
Yeah, my daughter, like last night when I was putting her to bed, my daughter said, "When is Pride? How come Pride hasn't started yet?" You know,
Oh,
like
God,
she
it's
can't.
Christmas.
She says it's her favorite holiday besides Christmas because let's face it, she doesn't get gifts. So
I feel like I need to do a better
I love
job because I mean, I don't know if we even talk about really Pride. I mean, we do.
here, I'll come hang out with them. I'll instill some pride in
You
their
take
pride.
my kids somewhere, take them somewhere for a Pride party.
Yeah,
They
I'd
go to
love
Highlight. They go to Camp Highlight. We call it Pride. It's good.
Yeah, totally. I mean, they have pride. Anyway,
Let's talk about the fact that this today is part 2 of last week's episode with Oliver. I am so excited for this.
this is when we get into the nitty gritty and we talk to a doctor.
Mm-hmm. So if you missed it, this is part 2 of our interview. Last week's episode, you got to stop what you're doing. You got to go back and you got to listen to it if you missed it. I mean, I'm saying that.
Yeah, Oliver, he's trying to figure out what his options are for making a family right now as a trans man who transitioned a while ago, a good time
Yeah,
ago.
if he wants to have genetically tied kids, he wants to know what his options are.
So
and-
obviously we don't know the answer to that.
No, we didn't.
No.
We didn't.
So we brought in a doctor, and to be truthful and fair, Oliver brought in a doctor.
Well, but that was so amazing is he wanted to share his personal journey, and then he was like, "Could I get a doctor?" And we were like, "Yes," because he was so committed to the fact that he wanted to make sure that his trans siblings, as he calls them, know what their options are if they're making medical decisions in terms
Yeah.
of their transition. And
he didn't want to
amazing.
give any false information, which neither do we. So we
Exactly.
got the world's most amazing doctor.
Wait, don't set Dr. Mok-Lin up yet. We got to say thanks to our Patreon folks.
Okay, so let's do this. I'll read the names, I think.
Okay,
Are we
wait.
ready?
We're going to
Okay,
special thank you to some new Patreon members.
I was
Yes,
going
this is a
there.
big deal.
I was going
You
there,
got- you
Robin.
got it.
Here we
You
are.
got it.
A special thank you to Aaron and Cassie Bucheri.
Yes.
I
I
think
feel
that's
good
how
about
you
that.
say it.
I think that's right.
Bucheri. That's a cool name.
It's a
Bucheri.
great name.
Alyssa McAfee. I don't think I messed that up. There's no way I could mess that up.
Could be Elisa.
Oh, Elisa.
I think it's
Dang.
Elisa.
I bet you it's Elisa McAfee.
Yeah, there's not 2 S's, there's only 1 S. Okay, Elisa
Okay.
McAfee.
Okay, and Cassandra. Okay, I got this. Cassandra Poyagis Osler. Poyagis. Poyagis?
Let's just call her Cassie. Thanks, Cassie.
Thanks,
Thank you.
Cassie. Cassandra Poyagis Osler. How about that? That sounds good. That sounds right.
It's in the ballpark.
Thank you so
Regardless
much.
of how we say your name,
Wow.
know that we love you and appreciate your support joining us in Patreon because you're helping us make content for LGBTQ families. You're helping us share all this representation and you're getting bonus content. And if you too want to get bonus content like, full videos
Like Cassie.
of most of our interviews, like Cassie, like our pal Cassie
Or
and
like
Alyssa.
everybody who already has heard the second interview because we dropped them both together for our Patreon members.
Correctamundo.
Correctamundo.
If you want that, you're going to just head to patreon.com/ovariestalk and you're going to join. Okay.
All
Okay,
right.
Jamie.
Part 2, Oliver's story. Okay, so Oliver brought the doctor in. This doctor is the best doctor ever. Dr. Mok-Lin.
That's, by the way, that's actually on her business cards. Dr. Mok-Lin,
It should
best
be.
doctor ever.
What an amazing human. What an amazing soul. I just really love Dr. Mok-Lin. I actually follow Dr. Mok-Lin on Instagram now. I do.
Oh,
Because
I didn't do that yet. I got to get on
with
that.
her. Yeah.
I'm sorry,
Works
Dr.
in-
Mok-Lin. I'll be there soon.
Yeah, works in, it might be Facebook. I'm not sure. I followed her somewhere. Obstetrics, gynecology, and reproductive sciences at UCSF, my hometown. Shout out to SF. Yeah, baby. Go
And
SF.
Dr. Mok-Lin knows her stuff when it comes to this topic.
She really
So
does.
Helen's going to roll the tape. She's not even going to complain, and she's super excited to do it
She
today.
is.
We had a little coaching talk before this.
Little
She's
powwow.
she's been meeting with a coach. I
She
mean,
has.
Helen is really showing some
She's-
real initiative.
She's turned the beat around.
And
She really
yeah,
has.
And she showed up and she said, I would like to roll the tape and I'd like to do it today. So I'm looking at you, Helen.
She's not real, guys.
All right. Welcome, Oliver and Dr. Mok-Lin.
Hi.
Thanks for having me.
Oh my gosh, thank you for coming. This is really
Part
exciting.
2.
Part 2. We've never done this.
2. This is our very first part 2 episode. Like you guys this is amazing.
Truly honored.
Oh, well, we're honored to have you, and we're honored to have Dr. Mok-Lin here to school us on some stuff and help us understand
Quite literally.
what your options are, Oliver, for sure.
What we want to start with where we normally do, we're going to, for anybody who might have jumped in and missed last week, shame on you.
Go back and listen right now.
And right now.
Right now.
But we still love you, and we hope you still love us. But for them, Oliver's going to give his 30-second elevator pitch again. And then we're going to have Dr. Mok-Lin's 30-second elevator pitch. It's going to be so good. Are you ready, Oliver?
Let's
Oliver's
go.
going to keep it under 2 minutes this time, I think. Okay.
I'm going to try. I'm going to try.
On your mark, get set, go.
All right. Oliver's going to speak in the third person because he wrote this for another person to say. So Oliver is a surfer, poet, whole leaf tea enthusiast, quad right energy projector with splenic authority, and astrologer. He's a white, straight, it's complicated, transsexual who's been on tea for over 10 years. Oliver is a leader in the new business paradigm and has developed his own special sauce, combining his years of professional digital work with his over 20 plus years study of esoterica to develop his brand and practice. Man.
Keep going. You're good. You're good. You got it.
Digital mystic. Can y'all edit that together, please?
Yes,
Thank
That
you.
was
Okay.
so good.
All right. Oh, I love it.
Thank
All
you.
right. Dr. Mok-Lin, are you ready for your elevator pitch?
I'm ready, and I didn't write anything down, so this is
That's
just
okay.
I know.
Yeah.
Most
But
people
that makes
don't.
it fun.
Yeah.
All right. Go.
I am Evelyn Mok-Lin. I'm a reproductive endocrinologist and infertility specialist at UCSF. I'm an associate professor at UCSF, University of California, San Francisco, and medical director of the Center for Reproductive Health and director of the Center for Reproductive Health's Transgender Reproductive Health Program.
Amazing. Look at that. 22 seconds.
Damn.
That's because I wrote nothing else. So
That was amazing. But also what I just learned, well, there's 2 very important things I just learned. The first thing is that you have gone to way more school than Robin and I, Dr.
Yes.
Mok-Lin.
Why did you lead with me?
Holy-
Lead with you on that.
Holy moly, I'm excited to talk to you. But also a very important thing that I just learned that Robin's going to be annoyed at is that you're in San Francisco.
Oh, here we go.
I'm
yes.
from San Francisco. So anytime I talk to anybody from San Francisco, with even now Oliver's rolling his eyes.
See, even Oliver's annoyed now.
I know, but hi fellow San Franciscan. Yay, San Francisco through and through. Okay.
Well, I'm a transplant because I grew up in New York City.
Well, so did
Yeah.
Oliver. Look at that. And we're
Yeah.
in New York, so we just flip-flopped.
Yeah.
Okay.
We
Yeah.
did flip flop.
Well, that's all I'll say about that, but that's very exciting.
So just to kick the episode off, we ended the last episode talking about how Oliver had reached out to us and really wanted to be the representation that he felt was missing in the trans community for young, particularly trans men who are making, decisions about their reproductive parts and maybe making decisions that are going to affect what they want to do down the road. And so he came to us. We did this amazing episode with him about his journey. But what we never answered was the question of that he originally emailed us about, which was can I do it? And Jamie and I were like, oh geez, we don't know. But we were like, let's find someone who can. And then Oliver found you, and then here we are. So can you tell us, start by maybe telling us a little bit about how you got involved in the trans community work?
Yeah, I'd love to. So many years ago, when I first came to San Francisco, so I did all my training in the Northeast, and then I moved out to San Francisco to take the UCSF job. And so when I arrived here many years ago, first few months of this new sort of faculty attending position here, I saw my first trans patient. They were here with their partner to try to start a family. And this was the first trans patient I'd ever seen. I mean, I trained at big programs, Harvard, Cornell, New York City, Boston. I had never seen a trans patient before. And
What year was this?
2013, maybe? Yeah.
Uh-huh.
And I felt so awkward. I'm sure it was awkward from their standpoint as well, in terms of just everything about the way I was talking, counseling, it wasn't my normal sort of flow because I was worried I would use the wrong pronouns, I would use the wrong names. It didn't really start off kind of well because our intake forms that all our patients fill out back then, and even now we could improve on it, but back then we're extremely heteronormative. Ask for the all the information is on the female, and then ask for the male. It didn't actually even say partner, it just said male, and then all the other sort of cis male kind of questions. So it already didn't start off well from that standpoint because they had spent all this time sort of frustrated by the intake forms. And then they see me and I was just sort of stumbling because I felt like I was going to say the wrong thing, at every point.
Deer in headlights.
Yeah. So I'm sure they were frustrated that they didn't get better care at UCSF. I'm sure they expected better from UCSF. I certainly expected better from myself. And so it was a very humbling experience. So I didn't see my next trans patient, I think, for probably a few years. And I don't know if that was partly because we just didn't have referrals or we didn't establish ourselves as like a place that was particularly welcoming. And of course, it's a small percent of the population in general, and we do something so specific, but still, I didn't see anybody for at least the next maybe 2 or 3 years. But during that time, I made sure that I educated myself. So I read more about the topic, and thankfully at UCSF we have amazing, being in San Francisco, but certainly being at an institution like UCSF, we have amazing adult and pediatric trans specialists kind of in the primary care world and endocrinology, the folks who are prescribing T and estrogen. And so I spoke to them a lot. I invited them to our clinic to talk to our staff. So I really did try to learn more about and just be more comfortable with it. And I think in that process, I engaged our other specialists to revise our forms to make sure that they were more appropriate.
Inclusive.
Right. And I think,
my God, you're an ally.
I know.
And a half.
Then I started to see a lot more patients. And I think part of it was because the adult and the pediatric internal medicine docs who were taking care of the patients sort of as their primary care docs were more comfortable referring to me, knowing that I was sort of aligned with them.
And doing the work, right?
Right. And then and then during that time, also in those few years, I also specialized in seeing pediatric oncofertility, or pediatric patients who are diagnosed with cancer. And I'm seeing them and their parents usually urgently with their new cancer diagnosis to talk about fertility preservation. And so I was already really comfortable with sort of seeing 10, 11, 13, 14, 15-year-olds and their parents, which is a whole different dynamic from, kind of our normal infertility kind of bread and butter.
Right.
So I was already comfortable with that population. My staff, like my medical assistants, my nurses were already working with the pediatric folks. So then when the pediatric endocrinologist started referring more of their patients to me, so they were referring before they started T, then it was sort of a natural transition for me to see all of those patients as well, because I was already used to see the options for whether it's for oncofertility or for someone who's about to start T are very similar.
Right.
And the timeline's sort of similar because it's urgent. In one group, it's urgent because they need to start chemotherapy. In the other group, it's urgent to start T because for all the reasons that, with the dysphoria. And
life-threatening, right.
Yeah. Right.
What I'm hearing, Dr. Mok-Lin, is that you were honest with yourself about a very uncomfortable situation. And instead of running from it, you delved deep in and did the work and learned what you could and started helping a community that you had known nothing about. That is just, if you're
That's
not
wonderful.
an ally I want in our corner, I don't know. I mean, thank you. It's just amazing. And I say our corner, just the whole LGBTQ community working to make forms inclusive. That's a huge thing. Just like these things that don't even come on a lot of doctors' radars, really, to be honest. So just wow, that's amazing. And I'm even more thrilled to have you here. So that's, I just want to say that.
That was a really nice way of saying what I said. Thank you.
Okay, ladies, Does it ever feel like the shorts you're wearing just weren't made for you?
Mm-hmm.
Me, yes, because I have short, stubby legs. I hate shorts on my legs. But it's time to try Title IX because they've got shorts built to keep up and to move with you no matter what you might get into. I really like that. Title IX gear is made by women for women. You like that, Robin, right?
I do.
Their clamber shorts are made out of super stretchy, abrasion-resistant fabric. So they're basically indestructible, which is important when you have kids. And thanks to a wide and very comfy waistband and tons of pockets, which we all love, you can wear them all day. They're basically some badass shorts, and I love them.
I love that. I love that Title IX designs and sells performance outdoor gear and apparel for women on the move. Women like us, Jamie, who are busy chasing trains, chasing kids, and just trying to be comfy, but also look good at the same time. It's actually harder to do than one would think. I like comfy clothes as well.
I know you do, Robin. I know you do. As do I. And that's why these clamber shorts are my new best friend. But it doesn't just stop there. Title IX gear and apparel is built to perform and it's made to last, Robin. From innovative swim pieces to bottoms that actually fit, every product is designed for women seeking out their next adventure, which, let's face it, we're adventure women. Or chasing their toddler, which is really the truth, like me.
Listen, I'm excited to bring these bad boys camping. The clamber shorts are technical enough for a day hike, comfy enough to wear on the couch, and cute enough to rock anywhere you go. So you just throw them on, take them off. We found our go-to hard shorts, Jamie.
They really do look good, and they feel good. I can't lie. I like them. I feel good in them. And guys, right now, Title IX is offering our listeners 10% off and free shipping on orders over $100 when you visit Title9.com/OCT.
Go to Title9.com/OCT and you're going to get 10% off and free shipping on your order over $100.
That's TITLENINE.com/OCT.
Oliver, let's start with where you were in your case and when you're beginning conversations with Dr. Mok-Lin about, where you're at and what's next.
It's actually a fantastic segue. And I did so much of this when we were on our call together, Dr. Mok-Lin, but I have to just double down on the thank you for giving a shit and for caring and showing up. And you are clearly so hugely intelligent and applying your energy and intelligence to a community that is so underserved historically and today is it again. I'm very emotional today, but it moves me to tears nearly. So how we got connected is my community has been mostly medically invisible. And that means there are not a lot of longitudinal studies on impacts of hormones on bodies who are switching their hormone at birth or whatever their assigned sex at birth hormone release would have been at puberty. For my kids coming up on blockers, they will likely only have one puberty, which will be with their gender confirming or affirming hormone. I did not have that. I've had 2 puberties. I've also had a series of surgeries, one of which was metoidioplasty, which included, Dr. Mok-Lin, I might need your help again, an oophorectomy.
Removing an ovary.
Yeah. Thank you.
Overrectum. Oh, that makes sense.
Yes. One of those words that I can spell it, I just can't say it. So if I were in the spelling bee, it'd be different. But I got in touch with Robin. I was 31, turning 32 at the time. And I was in this process of psychoanalysis, so on healing and intergenerational trauma. And that reminded me, oh, hey, I've got an ovary. And I was thinking, I want children one day. I wonder if I can reanimate this ovary. But the question was, are my eggs 22 years old or are they 32 years old? Which is what I asked you, Robin, and you're like, and we talked, and then, you were like, I was like,
good Lord, don't ask us. We're young. I was like, let's ask someone who knows what they're talking about, like Dr. Mok-Lin.
She didn't even come to me to ask the question. She was like, I don't know. I know Jamie doesn't know either, so.
And it's a specific niche. It's 1% of the population nationally in the USA is transgender. So, and a percentage of that is going to be trans male, right? So it's a percent of a percent.
Mm-hmm.
And so I have been in and out of the Kaiser Permanente system for years in the Bay Area. And there are great trans practitioners there who at the time, because I was in my internship for grad school, so I did, God bless covered California. I was with Kaiser. I reached out to them and said, hey, do you know anyone who specializes in helping me answer this very specific question? The first person on that list was Dr. Mok-Lin. And I'm me. So I went and found her email address and wrote her like hey, like you just over the bow, put the ask out there. Would you mind coming on this podcast to talk to y'all's listeners about what I am very passionate about, which is like body autonomy, especially with fertility? And she was gracious enough to respond, I think that day, and say, yes, absolutely. And so that's how we're talking today. And she and I had a conversation, and I took up a lot more of her time than I meant to, but it's just so fascinating talking about, I mean, Dr. Mok-Lin, you walked me through kind of my journey from 2010 to 2015 to now against just egg freezing all up. You also helped me answer the question, what happens to the eggs for trans male bodies once they start testosterone? And I would just love to ask you that question of like, are my eggs 22 years old or are they 32 years old?
They're 32 years old.
Oh,
So they
I
age
know.
I wanted them to
with
be
you.
22.
I know.
We are all like, damn it.
There's nothing right now that we know of, and people are working on it. There's a lot of research going on. I actually just read an article just yesterday about a startup, and it's so great to have more focus on sort of ovarian health in general in terms of like research space, but they're working on a drug that could potentially sort of extend the age of menopause, thinking that they could slow follicular loss. And that would be sort of groundbreaking
That would be amazing.
for many reasons,
Wow.
just to
Yeah.
not go through menopause at 50, 51 and go through at 60 or 70, and for lots of other
Yeah.
reasons. But as of right now, there's nothing that we know of that can pause or slow the attrition that happens constantly with the follicles. And follicles are little like cysts that contain an egg inside. And
Mm.
people with ovaries are born with a set number of follicles. So unlike people with sperm can regenerate. There are stem cells in the testes and you can regenerate. So the half-life of, the sort of lifespan of sperm is about 75 days. And so a whole new batch of sperm is made every 70 days or so, whereas ovaries are a finite number. So there's nothing right now that we know of that can sort of regenerate
But on the plus side, though, Oliver hasn't been going through, like, Oliver wasn't getting his period for 10 years. So all the follicles are still in there then, right? No?
They
No.
still
They still die?
They
cycle,
still
right?
undergo degeneration or
Oh.
apoptosis. Yeah.
Where does that go? I don't even
Yeah.
think we talked about this last time, but like so I've had for the list, I mean, if you listened to last week's episode, and LOL, the shame on you, if you haven't. So I don't have a vagina, a cervix, fallopian tubes, a womb. I only have the singular, I think it's my left ovary. I should really confirm that. Where do they go?
So you're not ovulating most of the time when you're on a high enough dose of tea, although some people still ovulate. It's sort of like traditional birth control pills. Most people don't ovulate on traditional birth control pills. Sometimes they do, which is why there are still accidental pregnancies. Birth control pills are not 100% effective, but most of the time people don't ovulate on birth control pills, but they still lose all the follicles that they were supposed to lose. So in the 20s, when there's a high number of follicles left in the ovaries, so most ovaries have, let's say, somewhere around 1 million follicles at birth. And then slowly people lose that over time until the sort of natural age of menopause is about 50, 51. So in the 20s, every single month, most people are losing about 20 to 30 follicles a month, even though you're only choosing one to grow and mature and ovulate. So when you're
How dare they? How dare they?
How dare they?
So when you're taking the pill or tea, you don't choose one to ovulate. So you don't mature the egg that's in that follicle. You don't ovulate. But all the follicles that you could have chosen from that particular month degenerate. So using birth control pills as an example, again, if birth control pills actually prevented us from losing the follicles, then we would see, since the invention of birth control pills, we should see the age of menopause be 60 or 70. right? But the age of
right.
menopause has been stable for like centuries, like 100 years. It's been
Does
about the same.
menopause happen when you run out of eggs?
Yes.
Oh.
Yeah.
You run out of
Okay.
eggs.
It's like a video game. Womp womp. You're out of lives.
Game over, right? Right.
Oh, okay.
So
Wow.
by the time people are in their 30s, most people have maybe more like 15 to 20 follicles that they're losing every single month.
Per
and then by the time
cycle,
you're
right.
per cycle, right? And by the time you're in your 40s, it's probably more like 5. And then slowly there's
So sad.
just 1, and some months there are
One.
0, which is why your periods get more and more irregular as we get closer to menopause.
Wow.
So the years of
Okay.
T prevented you from most of the time from ovulating, but all the follicles that could have been chosen still degenerated.
I see.
So Oliver,
that makes sense.
So Oliver, you have the ovary of a 32-year-old, but
Correct.
that's still
Hanging in there.
yeah, but that's still
That's
good
still
news, right? Because that's not geriatric at this point. We still have time here.
Right. Okay, Jamie, it's baby making time.
Huh?
No, not you and me, you crazy lady. It's time to share our code for the California Cryobank. I would never want to make a baby with you, Jamie.
Okay, whoa, slow your roll. You don't have to get so mean. Sheesh. That's fine with me, neither do I. But okay, yes, let's talk about how California Cryobank is offering our listeners a free level 2 subscription. You're just going to go to cryobank.com and use OCT to start shopping sperm now.
I mean, this is one of our best discount codes yet. And here are some of the reasons why you want to choose California Cryo for your journey.
Here we go. California Cryobank has been helping the LGBTQ plus community start their families for over 40 years. Did you know that? Their client services team is awesome and super helpful, I know from personal experience.
Yes, and they have all the info you need to make an educated choice, from a stringent donor screening process to personal essays to audio recordings, pictures, you name it, Jamie.
I know, and they have an at-home insemination option for you now. LGBTQ folks who want to get pregnant at home, this is for you. They have made it easy to ship vials to your home, guys. California Cryo seriously has our community covered. I really love that.
And they even say in their talking points, we work with all kinds of families, whatever that looks like. And inclusion matters. Damn it, Jamie.
It really does, damn it. Inclusion matters. So, folks, go ahead and start your search for donors today with a free level 2 subscription. Go to cryobank.com and use code OCT for free 90-day access to view extended donor profiles, childhood photos, adult photos, and express yourself items. Huge, guys, huge.
That's right. And that's cryobank.com and use code OCT for this free 90-day access. California Cryobank dreams start here.
They sure do.
Ours started there.
Yeah, mine too.
Can we walk through, like, if Oliver said tomorrow,
Great
I
question.
want to start, I mean, is harvest the right
freeze my
word? I
eggs.
want to,
Yeah.
Harvest.
Egg
yeah, I want
freezing, egg
to pull them
harvest.
out of there.
Yeah.
How would that happen?
Sure. Yeah. So one thing that we don't know that we should talk a little bit about is, so Oliver, you've been on T for 10 years at this point?
Yes.
10 years, right?
Yeah, over a decade.
Right. So what we don't know, so this is the big question that I and other folks in, sort of the trans reproductive health space, which, as you can imagine, isn't a very large group of people who sort of have a special interest in this, but we are trying to figure this part out, which is whether 10 years of T has an impact on quality. Right. What we're seeing so far is that it looks like it doesn't have an impact on quantity. It doesn't look like T somehow sort of accelerates the loss of follicles. We're not seeing that so far.
And how do
which
you
is good.
know that from like a sonogram?
That's a great question. So the early studies suggested that it might actually deplete the follicles, because when other trans folks donated their ovaries at the time of their oophorectomy, so they had their hysterectomy, oophorectomy, they donated their ovaries for research. And there have been multiple studies done now where they sort of sectioned the ovary, stained it, and looked under the microscope. And they compared the histology of an ovary from a trans person who's been on T for a number of years versus ovaries from cis women who are having their ovaries removed for other reasons. And the histology, or the architecture of the ovary, looks different. And there are more sort of like atretic follicles in the T exposed ovary. So there was a concern.
What's atretic?
Like degenerated. So there was a concern early on that T could deplete follicles sooner. More recently, and a lot of this has come out in the last few years, a lot of it from our group, from my group. So this is relatively new information in the last few years. But what we've seen is that when we have a group of trans men who have been on T and they want to undergo egg freezing, and we've done egg freezing on them, and we compare them to a cohort of cis women who underwent elective egg freezing, so matched them for age and sort of similar, otherwise similar background, they had similar numbers of eggs retrieved. So their response to egg freezing medications per round, per cycle, were similar to cis women who had never been on T. So that is reassuring in that every single month, because the max number that we can get for egg freezing is the number of follicles that your body is giving you. So the number of follicles that your body would otherwise deplete, that what we were just talking about in your 20s, you would sort of throw out 30 something every month.
Mm-hmm.
That's the max number that we can get in an egg freezing cycle.
Mm-hmm. Mm-hmm.
So the fact that we're getting similar numbers in trans folks who have been on T compared to cis women who have never been on T is overall reassuring.
So what do you need to know if the egg quality is good? Is you need those folks to have taken them out of freezing and to have gone through the process and then report back, right?
Exactly. So it's much harder because we have markers for egg number. So we can measure one's egg number by checking a hormone test, and we can do an ultrasound.
Mm-hmm.
I can check a hormone test on Oliver, and I can do an ultrasound on Oliver, and I can say this ovary this month has 15 follicles, 10 follicles.
Yeah.
So we have markers for egg number, but we have no marker for egg quality right now.
Quality.
Right.
Because
so quality.
I've been through IVF, and I've been through that whole process where they tell you how many you have.
Right.
And then you do find out the quality, but it's only after they have actually impregnated the egg.
Fertilize the egg with the sperm.
Thank you.
Exactly.
Yes.
Exactly.
Right.
So until we
that's
have,
when you would need someone to report back, right?
Exactly. So until we have outcomes, which will take a while, because it would take 1% of the population to then come back, first freeze eggs, which we know there's, access to care issues, of course, and financial restraints for sure.
Yep.
Mm-hmm.
Come back and use them. And then we can look at the embryos, we can assess quality that way. And then the ultimate outcome is, of course, pregnancy. So it's going to take us a while to figure that out. There have been, I've personally have had trans adults who've been on T who went through this process, went through IVF, and either carried themselves or transferred to their partner or to a gestational carrier who have had babies or are currently pregnant. And so we do have successes, but it's like
amazing.
It's not a big enough denominator for us to know sort of how it compares to someone who's never been on T.
Right. So there's no research, there's no rules as to the quality of how it's done, but it can be done, and we know that.
It can be done, right. And the other thing that we know is the studies are often 60 people or less, maybe 100 people, which already in the trans reproductive space is a big study already. But there have been other sort of studies and surveys where they asked trans folks to sort of answer the survey if you've been pregnant and had a baby, delivered yourself, and did you take T, how long? And so we know that people who've been on T, if they chose to stop and then conceive, that they've been successful. And thankfully, all the babies that have been delivered from those folks have been there's been no sort of increase in any sort of other findings, any birth defects increase or anything like that.
That's great.
Which is reassuring. So we know it can happen. And some people actually also reported that they got pregnant while they were on T. So I always tell they weren't trying. And so I always tell, especially my adolescent group, that if they're active with someone who has
you
sperm,
can still get pregnant.
Right. T alone isn't a good form of contraception, which of course makes them and their parents, who are always in the appointment too, like very squirmy. But
that's good to know, though. That is good to know. Yeah.
Right. So that's all reassuring too. But it's we don't know. Most of these studies, the folks that were on T were on it for a relatively short period of time. So there are very few people who, like Oliver, have been on T for 10 years and then now trying to have a biological child.
Because Oliver, it's almost like you came into this time period where egg freezing wasn't financially easy, and it wasn't as prolific as it is today. And so you're like this this sliver of a portion of people, right? In a way.
Well, I call myself a trans dinosaur
Which I
in
love.
this sense. So in 2010, I was under the care of a wonderful sits-on W path from a trans specialist standpoint. She was my endocrinologist and my top surgeon. And that was great because I was a baby. I was a trans baby. This is 2010. I was 21 or 22, and I said, okay, well, what are my options for fertility? And she was like, kind of like, she was very kind but direct, like kind of out of your range. Like in 2010, you would have to have an inseminated egg. You couldn't just freeze an egg. And I don't know as much. And Dr. Mok-Lin, I'd love to actually kind of kick it over to you at this point, because I didn't have options that I think now trans masculine people who go on T have options around egg freezing, that it was out of my range. I didn't want to think about a donor because I was 21 and 22 and talk about dysphoria when you're talking about sperm that you don't have, that you would want. Again, I'm a binary trans person. So like, you know, I don't necessarily have the worst amount of genital dysphoria these days, but I did then.
Yeah.
So it just was like, okay, well, F it. I'm not going to engage with this conversation. And then 2015 for my metoidioplasty. So 2 different surgeries, top surgery and testosterone was 2010. And then 2015, I got metoidioplasty, in which the removal of one of the ovaries, the hysterectomy, the hookup of my urethra to my neophallus, as they call it, or penis, that was all happening at the same surgery, same time. So, but that's 2 different people performing the surgery. There's a fertility specialist or OBGYN, and then someone who trains in phalloplasty and metoidioplasty. Again, those 2 options for trans male genitalia. But this OBGYN, who was herself queer, was like, you can keep an ovary, you don't have to keep an ovary, like it's kind of up to you. There wasn't necessarily like best practice or ovary standard of care, which I know Dr. Mok-Lin, you and I talked about. So if I would be super curious again, if we could talk about like the difference between 2010 and 2021.
Like what if 21-year-old Oliver showed up today?
Yes.
What would
Thank
be the
you.
path?
Yes.
Yeah, I'm very verbose. So that's the fast way to say that.
Well,
Which, by the way, I do just want to say this feels like we're probably breaking every HIPAA law imaginable. I feel like we're at the doctor with Oliver, and I'm like, so what? I want to ask about Oliver's care. It's like,
well, except Oliver is in control of his. Oliver's telling us the most about himself. So
That's true. That's true. Okay.
Verbal HIPAA release. Don't come at us.
Yeah.
Nobody sue our ovaries. Okay, go ahead.
So egg freezing didn't become sort of considered like universal or standard of care until about 2012. But for instance, at places like UCSF, we've been freezing eggs for at least 10 years prior to that, but it was always under an experimental research IRB. So we were doing it really kind of in the oncofertility space and then in the folks with cancer. And we said, you know, it's experimental in that we don't know how well they're going to thaw. We don't know how they're going to do, but this is your option. And they would have to sign like a research kind of consent form to be part of the research study because it was considered experimental. So we didn't do egg freezing for sort of non-cancer reasons until about 2012 later. So now, for sure, if 21-year-old Oliver came in, I would talk to you about freezing eggs while you still had both ovaries, because then we would have the maximum number that we can get, right? Because that 25 to 30 that we could access every month is a combination of the 2 ovaries.
Right.
And so while we still had, if you hadn't had bottom surgery, and this is, I would say, the majority of folks that I'm seeing, that they haven't had bottom surgery yet. Many people have had top surgery already, but haven't had bottom surgery yet. And then we would have access, sort of our kind of typical transvaginal access to both ovaries. So we would get the most number at a young age before you started T. So that would have been the ideal scenario, mainly because we don't, again, that sort of question mark of long-term T effects on quality, we still don't have an answer to. And it may be that we find out that there are no effects, and that would be great.
Yeah.
Then no one has to really think about this until they're actually ready to have a family. But until we know that, we're WPATH, ASRM, which is the organization that oversees my field, endocrinology societies all recommend that every trans patient who's considering T be at least counseled about fertility preservation first. Not that
That's
certainly not that
great.
it's like one of the things that you have to
That's
do,
good.
but that you at least receive some education about it and you feel like you have all the options open. And so
Right.
most of the time, that's our goal, is to try to, at this point, is to try to freeze
Those are just
eggs
such
before
huge
T.
life decisions
Yeah.
at such a young age when you're already grappling with, all the other medical or
Life-changing
whatever
issues. Yeah.
interventions. Yeah.
Right.
Like that is so much. And it's, and I'm thinking now about like younger people, like they're coming to the understanding or comfort level of being trans much earlier.
Yes.
It's like you hope there's parents that can step in and help them make decisions so that when they want to have kids down the road, it's an option.
Yeah, if they want it, that
it's
it's
so
always an
much.
option. You said
Right.
something, Dr. Mok-Lin, that made me think of a question. So say we learn that T doesn't have an effect on your follicles and they're healthy, and so you can do this stuff after surgeries. Usually, in order to retrieve eggs, you go in vaginally. But if the vagina is gone, that's still a possibility. You can still retrieve them. How do you get them?
Like going through the belly button, like that laparoscopic
It's
thing.
a great question. So we can do it. It is technically harder, and we tend to get fewer eggs because it's technically harder, but it is very doable, where we can go through the abdomen. So we don't have to do laparoscopic. We don't have to make an incision or anything. So we still do an ultrasound guided through the
Ooh.
belly, and the needle goes through the belly. But because there's a layer of fat, there's a layer, there are muscles.
Speak for yourself, Dr. Mok-Lin, not in this belly.
I was gonna say,
I'm
especially like the
saying.
younger folks, they have really good abdominal muscles. And so by the time you go through all of those layers, it hurts a little bit more when they wake up because it's more sore, but also the needle has less flexibility. Whereas normally transvaginally, we just have to go through sort of the vaginal mucosa or the skin of the vagina,
Right.
and then into the ovary. So it's a closer space. And so it's technically doable, but a little bit harder. But technically doable. And we do this sometimes because I have other patients who had hysterectomy and the vagina removed for other reasons, like cervical uterine cancer, for instance, or people who have really large fibroids and their ovaries are so far away from the vagina that we have to do it through the abdomen. So we do this probably like 5% of the time.
Is it a more expensive procedure? I mean, like out of
It's
pocket?
not more expensive, no. But
that's
you
good.
tend to get fewer, so then you might have to do it more
Again.
times. Right.
So Jamie, you've been through the process, and Robin, obviously you've talked to a number of people who've been through the process. It all still feels very sci-fi to me, mostly because I don't I don't understand. I think I called it reanimating the ovary, like you would
I like that. Yeah.
like
It feels
It
like
just
something
is.
from Tron.
Yeah, exactly. It feels very in the future to me. But so I've got a friend right now who's around my age, or an acquaintance, who's going through IVF. He's a trans man. He has not had metoidioplasty or phalloplasty, so he's got transvaginal access. But he was counseled to go off T and to start a regimen of estrogen and progesterone, and is just going through it mentally. And as we talked about on the last episode, what is the idea behind that? And do you have to do that as a trans man?
Good question.
Right. Is he planning on carrying? Is that why they're
No.
Okay, so he's just doing egg retrieval for IVF to transfer to someone else.
To his wife.
Got it.
Who is a cis woman.
Got it. So that was the norm for a while, and we're starting to challenge that really kind of in the last year or so. But the norm was that we said, well, we don't have data, but we don't have a lot of data in this space sort of anyway. So it sort of made sense initially to say, you should stop T for 3 to 6 months. That was sort of like the conventional thing to do, although it was not based on any data. So, but most people were saying, let's stop T for 3 to 6 months. So what people were doing is sort of ranged from stop T for 3 to 6 months, stop T until you get your period back, stop T, and then we check your hormone levels. And when you're sort of in cis female hormone levels, then we will then do the egg freezing or IVF cycle. So people were doing all sorts of things because it was not based on any data.
Right.
But everybody was stopping T. And so about a year ago, or maybe 2, at probably US Path, I was speaking at US Path, And I was talking to a couple of people, and we just sort of said, there is no, we know that you have to stop T if you want to carry, because if you continue testosterone during a pregnancy, it's teratogenic. So there's a higher rate of miscarriage, there's a higher rate of birth defects. So you have to stop T.
What's teratogenic?
Teratogenic means it's harmful to the fetus, to the baby.
Oh, okay.
Right. So you have to stop T if you're pregnant, if you're carrying. But the question was whether we really need to stop T just to retrieve eggs. And again, that sort of goes to, does it have an impact on egg quality? And if it did, does stopping it for several months sort of make a difference?
That's a really interesting question.
Right, right. But because it was not based on any data, I started to sort of say, well, we don't know that we need to do this. And then I was seeing folks who never actually came to me because they didn't want to stop T, right? So they would talk to their endocrinologist or their primary care doc, and they're like, we're interested in doing this. And their endocrinologist would say, well, you're probably going to have to stop T for 3 or 6 months. And they're like, that's not acceptable to me. So I'm not going to go see this person. And so I started sort of spreading the word a little bit that we don't know that this is necessary. And I had heard that there was a fertility doc in Canada that was routinely doing this with them on T. Unfortunately, this person, I don't think is academic. They probably just have a private practice and
just winging it.
Hadn't published anything, right? Didn't sort of report this in any formal way. So it was kind of word of mouth, but it was a good sort of point of discussion in that we don't actually know that you need to. So then I started offering to folks that I was seeing with a discussion, sort of, if you want to, we don't have any data for or against it, if it would be more dysphoric to stop. And if you would otherwise not do this, but you really want to do this, you just don't want to stop T. And I don't have any data to say that it actually is harmful, then we should just have you continue it. So in the last 3 to 4 months, so we're talking like very recent data, 2 case reports that came out that one person stopped T for 3 weeks, so a much shorter time, did egg freezing, had a very good response. One person stayed on their T, but was on like kind of a low dose T to begin with, but they stayed on it for the whole time, also did egg freezing and did very well. So proof of concept in terms of that you can stay on the T and still respond, because that was always one of the questions is quality, but also will you respond to the medications?
Right.
I have had several patients myself that stayed on T that I did the same, that we're writing up with one of our OBGYN residents. So we're writing it up and we're going to submit it for publication as well, because we've had several ourselves. So now if I see someone, we would have a discussion. And some folks will say, I don't mind coming off of T. They've sort of gotten the effects of it and it's not super dysphoric for them to stop. And definitely others will choose to stay on.
Right.
So we don't know that you have to.
Wow.
Yeah.
But
that's like a game changer.
Yeah, work is being done and changes are being learned about daily, it sounds like.
Amazing.
Wow.
Yeah.
I want to like this, the level of knowledge here just being dropped is so huge, and just calling out the difference between 11 years ago, having this conversation would have been very, very different versus now. And I want to be super mindful of time, especially like, in my industry, we're like, we're not doctors here. Like when there's time, like we can keep going, but literally we have a doctor on the call. So I do want to be mindful.
This doctor probably has a lot of important work to do.
Mindful of the clock, but there are 2 territories that I still would love if we could cover. One of that is like the incredible work around the policy that you've been doing. Because I think that is deeply important. But I'm also selfishly, because I am an ovary keeper, any ideas for recommendation for follow-up care along the lines are not even on the fertility side of the house, but like can't do a pap smear. I don't like ovarian cancer, as we've talked about, is hard to detect. Like if there are any suggestions that we know of for my fellow trans men out there, or cis women who, to your point, have for medical reasons have had to have similar surgeries in this regard, like what the standard of care might be for that. And I know that those are 2 big questions, but I will defer to where you are called to speak to.
I also think you just came up with the title of a book, Oliver, The Ovary Keepers. Somebody needs to write that book right there. Okay. The Ovary Keepers.
And from the trans dinosaur.
Yeah.
That's your subtitle. Subtitle. From a trans time.
Well, so I
Amazing.
think, and certainly ovarian cancer is not specifically my expertise, of course, but and there's a whole other like fellowship after OBGYN that you could do for that, whereas I branched off of fertility. But it does bring up a good point, which is I think sort of earlier in the days of bottom surgery, it was more routine to remove the ovaries, both of them. And it sounded like, Oliver, you had advocated for yourself to keep one of the ovaries. Otherwise, probably
Correct.
they would have removed both. And I think that was pretty common.
Correct.
And the thought was that there was some concern initially that long-term T potentially could increase risk of ovarian cancer, although that's not the case. So there's no evidence of that. And then there was sort of the other thought of like, you don't need the hormones because you'll be on T. So I think now the as far as I understand it, the folks who do a lot of the surgery now is that there's still a conversation. So you could, if it's extremely dysphoric to keep an ovary, they will certainly remove them. But there are a couple good reasons to at least retain at least one, which is one that, of course, your family planning goals may change. And as long as you keep one, you still have the opportunity to do egg retrieval and IVF later. The other really important thing I think to point out is that while you don't need sort of the estrogen from the ovaries if you're on T for general sort of health, is that there are significant trans people who can't access care at all times of their life, right? There's high rate of homelessness.
Yes.
And so you
Yes.
can't necessarily know that you'll always have access to T. And if your insurance drops or if you can't access it, then
Yes.
you would still have an ovary to produce some hormones for sort of general health and quality of life as well, because otherwise you would have a lot of like symptoms. But for bone health, heart health, there are other sort of considerations. So I think it deserves a conversation for sure. But I think more and more people are retaining their ovaries or at least one ovary. And then what was
Good.
the other question about policy, right?
Yeah.
Yes.
Yeah.
So
I know you've done great work.
So this is an area that is, I mean, really, in my mind, the ideal would be that everyone would have insurance coverage for medically indicated fertility preservation and infertility, right? I mean, IVF is so expensive. Egg freezing is so expensive. In many ways, it's much easier to have sperm because collecting its sperm is much easier than collecting eggs, and freezing sperm is
True.
much cheaper because it's easier. And so people with sperm can produce a couple of samples. It's relatively inexpensive, and there are a lot more options with that respect. But freezing eggs is $10,000 out of pocket. IVF, I'm sure Jamie knows how much that costs, but it's so expensive. And so ideally it would just be universal coverage. There are many states that are working towards that. California, last year, in 2020, right? It went into effect January 1st, 2020, but I had gone to Sacramento in 2019 with my colleague and one of our residents to help lobby for this bill, and it got passed. And it's SB 600, but it's a bill that mandates large payers. So it's still, work ways to improve this because it excludes Medi-Cal, which of course is like the group of people that really need this the most. But one step at a time, it mandates large payer insurances like Blue Cross Blue Shield, United, Kaiser, Aetna to cover medically indicated egg and sperm freezing. So they specifically wrote the bill to say medically indicated to give us the flexibility to say it could be cancer, it could be gender dysphoria, it could be that they already had one ovary removed for a large cyst and now they have a recurrent cyst. It could be it doesn't have to be necessarily cancer.
So you can write it to your particular situation.
If I said it's medically indicated, then this Aetna should cover it.
That's amazing.
Amazing.
That's huge.
Amazing.
It is huge. It's huge.
It's a big deal.
Yes.
Well, can we ask you to leave us with any tips or thoughts that you have for the trans community, for folks who are coming up, getting in this space? They're 21-year-old Oliver. What do you say to them?
And they might have been on blockers this whole time, and the whole
that's a whole other
let's
discussion that I just love. I just think it's so great. First of all, I think it's just so great that this kind of generation can have access to blockers and not ever have to, they won't need top surgery, right? Because they've never had breast development. I mean, just to not have to go through and be able to enter middle school and high school as themselves,
as
it's
they
just
know, as they
amazing,
are.
right? I just think
Yeah.
that's like the blockers are probably, I think, the best, one of the best developments for the trans community. But it has posed an interesting issue for fertility folks because traditionally, we had thought that you can only access eggs, we can only get mature eggs if you've gone through puberty, if you've had your first period. So for up until even now, if I see an 11-year-old who hasn't gone through puberty, whether they have cancer or any other thing, we would say we can remove an ovary and we can freeze tissue. And we're hoping to, down the road, be able to extract immature eggs from those ovaries and grow them in the lab. And that's going to take, probably at least another 10 years of research to be able to do that. You can do it in mice, but no one's been able to do it in humans yet. But probably in 10 years, we'll be able to do it. So we can freeze an ovary.
When that child might be ready to have kids. I mean, at this time right now, right?
Right. So we can freeze an ovary, but it requires a laparoscopic surgery, which, they're 11 years old and there's a lot of considerations there. But what we recently did, I'm trying to remember if I published it yet or I submitted it, but we recently, and a couple of people around the country that I'm in touch with have also demonstrated this. So we know now we can do it, is that we've had a number of kids on blockers who are about to start T, but they haven't started T yet, but they've been on blockers this whole time. And we said, let's try it. No one's ever really tried it because we figured it wouldn't work. We gave them the medications, they did all the injections, and we were able to get mature eggs. So it was like a huge, groundbreaking sort of proof of concept here, is that we can actually get mature eggs in like a relatively short period of time, 2 weeks of injections.
Wow.
From
And
people
this
who
is
have never gone
fertility
through
meds.
puberty.
Like,
the same ones that you did,
right.
The injections that you did. We had
Ovidrel, Follistim.
Exactly. We had previously thought that, one, it wouldn't work, or that it would take so long, 60 days of injections to grow these immature follicles. But it actually worked. The first report came out,
holy moly,
I want to say 2020 or 2019, really recently. And it was in like JAMA, JAMA. It's a huge medical journal because it was such a big deal. And it was a case report, which like these journals almost rarely publish sort of case reports. They publish like major studies and that sort of thing. But it was such a big deal that they actually published it because it was the first time anyone has ever shown this. And that particular clinic gave this adolescent 30 days of injections, which, as Jamie, as you know, is a lot longer. You probably did 12, 14 days of injections.
Yes.
But subsequently, including in our clinic, the patient that I tried this on only took about 12 or 14 days. So like a normal period of time. We did kind of our normal things and they got mature eggs.
That is amazing. But we don't know if those eggs can be
right.
I'm using the wrong
fertilized
term.
And
fertilized.
Right. So that will be again sort of the next
That's
step.
the next
Wow.
It's all happening in real time.
That's amazing.
But I feel like the real takeaway here is that anyone who has any questions just needs to reach out to you, Dr. Mok-Lin. I mean, I feel like if that is not the answer, I don't know what is.
Well, and I think everyone should have a good consult and conversation with a fertility specialist.
Yeah.
And the field is relatively small. Certainly the field, again, within like trans reproductive health is very small, but there aren't that many REIs, reproductive endocrinologists in the country, and most people know each other. And so what's happening is people will start emailing each other, or they'll send me a message and say, I have this person who's doing this, what can I do? And so even if they're seeing someone local to them that isn't necessarily super experienced with this, they'll reach out to someone who is. And so everyone should have
that's nice.
a conversation of what their options are.
Amazing.
Basically, you're like Charlotte from Charlotte's Web, and all of the web fingers go out to the other doctors and they come back to you, and you know the info is what we're saying. So no matter who you talk to, they should go to Dr. Mok-Lin and ask her.
I'm picturing a bat phone. I'm picturing a red bat phone.
Like,
and it's like ringing constantly. She's like, no, don't do that. Yes, do that.
No, I mean, thankfully there's a few, probably like a handful of us that are kind of working on this more than others.
Doing the good work, as I like to call it.
Yes. Well, thank you, Dr. Mok-Lin, for just dropping all this knowledge. And thank you, Oliver, for your absolute openness and willingness to letting not just Jamie and I in, but all of our listeners into your process so that we could all learn. I mean, just thank you so much,
Yes.
both of you.
Yeah.
Thank you.
Yes, Dr. Mok-Lin, thank you so much on behalf of me and all the trans people in the world. Like, thank you. And Jamie and Robin, thanks for the platform and for the ability to share the story and get Dr. Mok-Lin's essentially consult and guidance along my personal journey, and hopefully for the listeners out there, younger, older, in between, who are considering family planning, there are options for us. So
there is hope. There is hope. I love
Mhm.
it. I love it. Thank you so much.
I still love Oliver, and now I also love Dr. Mok-Lin.
How could you not? How could you not?
I mean, isn't it amazing how she just like learned about the community, had that bad experience, and then was like, I better get more knowledgeable about the community so I can serve them.
That is why I love her so much. She saw that she had a lack, like she saw she was lacking, and instead of running from it, she faced it head on and went hardcore at it. Thank you so much, Dr. Mok-Lin.
And then she became a champion for our people, which I
Thank you.
love.
Thank you. And also Oliver, I think both of us feel so completely grateful that Oliver reached out and wanted to share his story and was so open and vulnerable and honest. And, I know that in our community and everybody who listens to this, all he's going to get is love back. So that's wonderful.
Yes.
But it's still just what a treat, what a gift that Oliver just gave us and everybody, right?
Yeah, I just feel exactly like what I said in the middle of the interview. It felt like we were sitting in on someone's doctor's appointment, which was so beneficial for Oliver to grant that level of access so he could ask the questions and then other people can learn from him. Just a gift. A gift.
Thank you. We feel honored that we got to share that experience, and we hope you guys enjoyed the episode.
Yes.
All
So
right.
folks, we're going to mention it again. We want you to go out and get our books. If these our books, I guess gave us a second book, Jamie, as if we wrote two.
As if we did. We have not. We have not.
Just the one. If These Ovaries Could Talk, the things we've learned about making an LGBTQ family. And it is available at all major retailers. And if you want to buy locally, which we definitely support, you're going to hit IndieBound and they'll tell you where to get it. And you can get the audiobook with us reading to you, which, I don't know. I think that's a plus, but we're never sure.
We're never sure.
It's available at Amazon and iTunes.
Yeah. And if you do get it, don't be afraid to review us on Amazon and Goodreads. And, Pride's coming up. Is a great gift. It's Pride Month all month. Give your gay friends and your straight friends and every friend you have the gift.
Or your parents, Jamie.
Book.
Like if you're about to start trying, which a lot of our listeners are, that's a great gift to help your parents understand our community and what our journey is
and
like.
not be afraid.
Yeah.
Of what you're about to undertake. It's totally doable and it's totally beautiful.
Totally beautiful.
It's so gorgeous, our families. I love our families. They're so beautiful. I don't know who I'm talking like right now. I don't even know what that accent is.
I don't know what that was.
Okay. So we're going to keep this conversation going, guys. We are all over the social media. We can't stop, won't stop. Ovaries Talk on Twitter, Instagram, and Facebook. We are If These Ovaries Could Talk on YouTube, where you're going to see recordings of our live streams that we do every Thursday at 4 p.m. Eastern Standard Time on Facebook and YouTube, guys. Go check us out because that's fun. You get to interact with us. You can also support the podcast and join our community on Patreon at patreon.com/ovariestalk. And you're going to get all kinds of bonus content. Like, for instance, the fact that we dropped both episodes right away on Patreon. So you could listen to both of these episodes back to back. Like you could have binged us. You could have binged the ovaries. Who doesn't want to binge those ovaries?
Binge our ovaries.
Binge
that sounds like
ovaries.
a side effect of IVF. And thank you to our sponsors, Title IX and California Cryo, and a huge, huge, huge thank you to all you folks who are already our Patreons. You are helping us make this show, and we couldn't be more thankful for that.
Really, we couldn't do it without you. So,
our wives would not let us.
Absolutely not. They barely letting me do it right now. I'm in the doghouse because this has been an ovaries-filled weekend.
All right, on that note, eggs.
Ovaries.
Out.
If these ovaries could talk, they would say,
Eggs, ovaries, out.